Hello everybody. So as you all know, NKX 3.1 is homeobox transcription factor. So it also acts as a tumor suppressor gene. It's located on the chromosome 8p21. HC positivity is based on the nuclear staining. It is expressed in the luminal cells of the prostate. In the basal cells, it's usually negative. It is downregulated in high-grade prostatic adenocarcinomas. It is very useful in identifying the prostatic origin of a tumor. So the primary clinical utility is mainly because of it being able to identify prostate as the primary organ. So it's specific for prostatic adenocarcinoma. So you can use it in detecting metastatic deposits. So whenever there's a carcinoma of unknown primary, if it's positive, it indicates prostatic origin. It is very useful in small core biopsies in identifying the prostatic origin. It can be used in differentiating prostatic carcinomas from adjacent malignancies from bladder and colorectal malignancies. It is superior in specificity over the already existing PSA marker. It can be used in poorly differentiated tumors with a higher sensitivity rate. Recommended use is with other markers such as PSA or AMACAR. That in conventional prostatic adenocarcinoma, sensitivity and specificity of almost 95 to 100%, in metastatic anywhere between 70 to 95%. It is reduced in other variants or high grade prostatic cancers and neuroendocrine carcinomas. It's very useful as it is negative in malignancies from adjacent organs like bladder, colorectum, and even in other organs such as breast malignancies. Weak staining may be seen in some types of mammary and salivary gland tumors. Weak or focal positive is noted in very few non-prostatic tumors, and hence it's mainly used in identifying these metastatic tumors as prostatic origin. It's a nuclear marker and hence it can be used with very high sensitivity and specificity. It is preserved in low-grade tumors. So in benign prostatic glands and your low-grade prostatic adenocarcinomas, it shows almost 100% positivity. It is lost in usually high-grade tumors or tumors with neuroendocrine differentiation. Therefore, in such tumors, even if you see a NKX 3.1 negativity, we have to use it with some caution. The limitations being the fact that it is lost in your high-grade tumors, neuroendocrine prostatic malignancies, and occasionally can be seen to be positive in few subtypes of breast malignancies like your lobular carcinomas and in salivary duct carcinomas. It may not be useful to differentiate between prostatic acinar adenocarcinomas from small cell carcinomas of prostate, as both may be NKX 3.1 negative in your high grade prostatic malignancies. It should not be used alone, and it's always preferable to use it along with PSA or AMACAR. Finally, to summarize, it is a very good marker to identify prostatic origin and mainly in metastatic tumors. Thank you.